Hello, I'm Dr. David Hornbrook, the Clinical Director of Education and Technology at Keating Dental Arts in Irvine, California. Welcome to our weekly podcast on Dental Up. We're in for a real treat today. We are actually sitting at Nobel in beautiful Yorba Linda, California, and I'm with Tom Olson. Welcome, Tom.
Hi there, good to see you.
You know, I know you're a busy guy, and I appreciate you taking the time out of your crazy schedule. I've got this little slot in between your busyness to spend with me, and it means a lot to me.
Pleasure to be here.
Yeah,
Thank you for coming here.
Yeah, it made it nice. You know, I'm a practicing clinician. San Diego's home for me, and I work with Dr. Peter Nordland, among others, and you know Peter. And the nice thing about it is all he uses is Nobel. So
grateful for that.
And I got the tour. It was fabulous. I got a personal directed tour from the president and GM of Nobel, so made that much more enjoyable. But it was very cool because you said approximate percentage, all the replace, you said implants are
produced here.
Manufactured here. And then as far as percentage, and I know I asked you this before, but approximate percentage of the implants?
It depends, but half of the production more or less is here and the other half is in Karlskoga, Sweden, but both facilities can make the full line of products.
Okay, awesome. Yeah. So as I was probably looking at some of my implant abutments going on.
Hopefully so.
I'm sure. You know, I'm going to put you on the spot a little bit. You know, there's implants are competitive, and it's a competitive market. Yeah. We have, you know, manufacturers that are trying to make it cheaper, and you know, all these things, whether it be this country or another country. And being a Nobel user, and I'm a firm believer in that. In fact, even when I send something to a lab I don't routinely work with based on the surgeon's input or even the patient's input, you know, I always order my Nobel parts and send them to the laboratory because I'm always concerned they're going to, you know, possibly they would do some clone that was inferior in my opinion. So with knowing that competition and the opportunity maybe for a lab to buy even a cheaper clone, why would a doctor, whether it be the general practitioner who's kind of directing treatment, or the surgeon in the laboratory, say, you know what, we're using Nobel.
Yeah.
What would drive that conversation?
Yeah. Well, I think this is a fairly hot topic right now around authenticity. And obviously there are a lot of clone products there that are really not made according to manufacturer specifications. I think the backside of this is there is a lot of clinical implications for this when these parts aren't functioning correctly. And unfortunately, a lot of this is not seen until the treatment is downstream a few years. Mm-hmm. So if you listen to a lot of the lectures today that are going on by many clinicians, not just ours, but many clinicians, they are starting to talk about the consequences of using components that they believe to be compatible and that are claimed to be compatible.
Right. Yeah, we just had one in my practice. The patient came in and said the implant crown was loose, right? And we thought, you know, something where we make a little hole and screw it back on. Right. And we didn't place the implant. We didn't do the restorative even. We drilled through it. My associate actually did it. Drilled through it, unscrewed it, and it turns out the implant hex itself was cracked. Yeah. So I mean, that's not just a new screw and a new abutment. And we called the laboratory because the patient knew the laboratory, and sure enough, they used a clone part, and that was a huge compromise for that patient. Yeah. The implant comes out, new implant maybe, and to me, it's not worth it. Whether it be $40 for a screw or $100 for this, it just doesn't make sense.
Yeah. No, and ultimately the patient pays the price for this. Obviously, there's an inconvenience from a clinical perspective when they have to do these remakes, but the patient is the one that bears the risk on this.
Yeah. You know, I saw we had this conversation before we went on air about Brandemark, and you know, I was at UCLA in my third year in 1985, and I saw Brandemark. I think that was his first tour that he toured around the States, and thinking, that's not going to work. That's not going to work. And also, where's my next denture going to come from so I could graduate on time? And you know, I look back at that moment when I thought, you know, this is something, honestly, that this is just kind of disappeared with all these other things that have come. Where do you know, obviously it's a success story. I mean, implants are proven. It's something that, you know, I think is ideal treatment versus a bridge in most applications. Where do you see it going from here? I mean, you're in a good place now. Yeah. Especially Nobel. Yeah. Where do you see?
Well, you know, look, all the demographics are trending in the right direction. I think, you know, what Professor Brandemark created, you know, we're seeing the reality of that today. The unfortunate thing is that dental implants today, even in, you know, a well-developed country like the U.S., is only penetrated about 10%. So today, you know, the numbers are, you know, you've got 35 million people missing all their teeth today in the U.S. You've got over 178 million missing one or more teeth. a very small percentage of these ultimately are treated with dental implants.
Right.
So the awareness level is increasing. I mean, certainly across the industry, and certainly from a patient perspective, the awareness level is increasing. Training at universities is becoming more focused on this. I think a lot more being done around dental implant training. So I think going forward, I think the demographics are working in the direction, because you're seeing a lot more patients. I'm sure you're seeing them in your office with failing dentition, and implants provide a good alternative for that.
Oh yeah, absolutely.